learning about screening. Screening is the 4th chapter of Park book, okay? তো আজকে ক্লাসের পরে ওই চ্যাপ্টারটা গিয়ে পড়তে হবে কারণ later we will be solving problems. And this comes as an epidemiological question. This will always come as an epidemiological question in your practical exam. So it is very important. Now what do you think screening is? Bolo? Any idea what is screening? So screening is basically the detection of a disease in an apparently healthy population. The keyword is apparently healthy, okay? So you have to tell that to the person who will ask you, or you have to write as such if question comes, that screening is the detection of a disease in an apparently healthy population, okay, and then to take some corrective measure. So screening, let's see, okay. Now screening is one type of test. Another type of test is called gold standard test. There is a test, something called gold standard test. Now what is that? In medicine and medical statistics, gold standard or criterion standard or reference standard, whatever, reference test, it is the diagnostic test or the benchmark or the most accurate test that is the best available under reasonable conditions. That is for detection of a disease which is the best diagnostic test that will detect most accurately. That is called the gold standard test for that disease. For example, gold standard test for tuberculosis is CBNAAT. ঠিক আছে? Nucleic acid amplification test CBNAAT. Then for hearing it is audiometry. For malaria or for filaria, gold standard is microscopy. Okay? And for viral diseases there is RT-PCR. Okay, for reverse transcriptase virus is RT-PCR. So this gold standard test is there. So why do we need this screening test then? We need this screening test because people who do not have signs and symptoms but who have the disease or the infection, they will not come and do this gold standard test. Okay? So we need to have some rapid test or some very other types of tests which can screen very efficiently whether the person has disease or not, and then you prevent that disease from progressing in the body. Okay? So you stop them at a very primary level. Means তোমরা আগেই কোনো ডিজিজের কমপ্লিকেশন হওয়ার আগে স্ক্রিনিং দিয়ে সেটা আর্লি স্টেজে ডিটেক্ট করা যাবে and you can then prevent the disease from progressing further. So in the early stages of a disease, the screening test is used. So screening test is only then applied if the disease can be detected at an early stage. If a disease is such that it can only be detected at a later stage and never at an early stage, then there is no use of a screening test in that disease. So if a disease can be detected at an early stage, okay, in apparently healthy population, when the signs and symptoms haven't been, coming up in the person, then that screening test is used in those kind of situations. Okay. Now what are the other tests or methods used for the screening of the disease? For example, which are not gold standard. For HIV, there is a salivary screening test. Okay, salivary screening test. What is a gold standard test for HIV? RT-PCR, are you sure? HIV? ELISA is a good HIV is ELISA, one confirmatory test, but what is a gold standard test? Western blot. Western blot is the gold standard test. Okay? And there is then ELISA. Okay, not RT-PCR for HIV. Okay, history of cough for more than 2 weeks. You can even take a history or take a certain type of history and do the screening as well. Okay. For TB, you can take history of cough more than 2 weeks. If you can screen by that or any other symptom, with other symptoms you can screen a person for TB. Then there is the rapid diagnostic kits for malaria, for dengue, for Japanese encephalitis, for many diseases. Nowadays these rapid diagnostic kits are available which are used in the population by the health workers for screening of certain diseases in a regular fashion, in a regular period. Then there is the Apache instrument for the ICU patients. Then high risk pregnancy, indicator for the high risk pregnancy is maternal height or maybe maternal nutrition. That can be used as a screening test for detecting high risk pregnancy. So, all these examples are there, they are not the confirmatory or the high gold standard of the diagnostic test. These are some tests that can detect the disease at an early stage and help in the prevention or progression of the disease. That is why screening test is needed. Now, sensitivity and specificity. Have you heard of these terms? Sensitivity and specificity. So, what you do, like that you make a cross table 2 by 2, also known as contingency table, to plot the cases diagnosed by the gold standard test against the cases diagnosed by another screening test. Means what is there, as you can see, there is something called HbA1c. Okay, this HbA1c किसे use है? Diabetes mellitus. Diabetes mellitus. Okay. So, and one is diabetes mellitus and diabetes mellitus है HbA1c ते तुम्हारा gold standard test धरने वाला है. Okay. And according to the HbA1c cutoff, you can categorize persons as diseased and non-diseased. Okay. They are diseased and non-diseased. So, this diseased person, as you can see, so they are the true disease, they are assumed to be the true disease, that is who truly have the disease, okay, who are actually having the disease, that is the diseased person. And the non-diseased person according to HbA1c is the person who do not have the disease. We are assuming like that. Now, this test is also not 100% foolproof obviously, but gold standard test is usually assumed to be the confirmation that which person has the disease actually and does not have the disease actually. Okay. So, in the column you are putting the gold standard test, and in the row what you do, you in the row you put the person who is testing positive for screening and negative for screening. So, here according to the screening test, so what can be a screening test for this diabetes? Certain people are coming negative, okay. So, RBS can be considered like a screening test just to screen previously that which person might have diabetes and which person might not have diabetes or high chance of having this diabetes. But the confirmatory test is HbA1c. So, you now putting the screening test in the row, okay. So, you always, whenever there is a screening problem, you always put the test in a 2 by 2 table. You put the gold standard or the diagnostic test in the column and the screening test in the row. মনে থাকবে? ঠিক আছে, screening test in the row, diagnostic test in the column. So, whoever is under the diagnostic test, whoever is diseased, that is this total, they are the true diseased. They are the true diseased. Okay. They are the true diseased. But people are, these many people are coming to be positive on the screening test, right? So, these many people are coming positive on the screening test. So, what are they then? They are test positive. Okay, they are test positive. So, now you can see that there is something called true diseased and there is something called test positive. So, true diseased are not equal to test positive. So, in every test they will not come to be positive. Some test will wrongly categorize them as negative, some test will wrongly categorize negative people as positive. Okay, so that is why the accuracy of these tests differ. Whenever a test, especially a screening test, will come to be positive, always take it with a pinch of salt. It might be, if it is overly sensitive, then that means it will categorize the non-diseased person as diseased. If it is less sensitive, it will categorize the diseased person as non-diseased. So, it will make mistakes like that, no test is foolproof. But to make this work, you have to understand that screening test whoever is coming positive on the screening test, they are test positive, not true positive, or not the true diseased. Okay. Then so people who test positive among those with the disease, that is called sensitivity. একটা একটা করে দেখো, ঠিক আছে, একটা একটা করে দেখো। People who are testing positive among those with the disease, among those with the disease, তাদের মধ্যে কতজন পজিটিভ আসছে? ওকে, দিস ইজ সেন্সিটিভিটি। মানে এখানে ধরো এখানে অলরেডি নাম্বার দেওয়া আছে। ইন এনি কেস, if this is the number of people who are testing to be positive among the diseased, মানে গোল্ড স্ট্যান্ডার্ড টেস্টে যারা পজিটিভ আসছে, ঠিক আছে, কামিং টু বি পজিটিভ, সেটা হচ্ছে ট্রু ডিজিজড-এর মধ্যে যারা পজিটিভ আসছে, দ্যাট ইজ দি sensitivity. So sensitivity is A divided by A plus C multiplied by 100%. ঠিক আছে। সো সেন্সিটিভিটি এটা এভাবে মনে রাখবে, কলমটাকে অলওয়েজ কলম টোটালটা নেবে। ওকে, A divided by A plus C, কিন্তু এইভাবে আবার পরীক্ষার হলে জাস্ট A divided by A plus C লিখলেও হবে না। এটা কি, সিটা কি, সেটা তোমাকে ডিফাইন করতে হবে। সো হোয়াট ইজ এ ট্রু পজিটিভ? C is false negative. Means false negative. They are positive actually. They are cases, but they have been falsely denoted as negative according to this what? According to this screening test. Okay. Whatever is positive and negative, ঠিক আছে, they are all denoted respective to the screening test, because আমরা স্ক্রিনিং নিয়ে কাজ করছি এখানে। তো স্ক্রিনিং টেস্টে যারা পজিটিভ এসছে among the disease that are true positive, আর স্ক্রিনিং টেস্টে যারা নেগেটিভ এসছে among the true positive that are false negative. বুঝতে কোনো অসুবিধা হচ্ছে এখন বলো, এখনো বলো, এনি কনফিউশন? মিটিয়ে নাও কনসেপ্টটা, বিকজ ইট ক্যান গেট কনফিউজিং ইফ ইউ ডু নট আন্ডারস্ট্যান্ড। Should I explain again? বলো বলো, yes or no? Should I explain again? It's okay. Explain again. ঠিক আছে। Those who test positive among those with the disease, test positive in the respective of the screening test. Those who are testing positive in the screening test among those who are truly diseased. এই HbA1c তে এতজন ডিজিজ এসছে, 500 জন ডিজিজ এসছে, 500 people have come positive. So I am assuming that 500 people only are having the disease and no other else. These 500 people are only having the disease. Now when I do the screening test, the people who are coming positive on the screening test, so the people who are coming positive on the test among the true diseased, the total diseased, that is called the sensitivity. So it is, if it is denoted by A and this is A plus C, then it is A divided by A plus C into 100%. But what about this? Some people will come to be negative on the what? Negative on the screening test. The diseased person, some people might come to be negative on the screening test. So that is called false negative. They have been falsely denoted as negative. Understood? ঠিক আছে, তো ট্রু ডিজিজড-এর মধ্যে যারা ট্রু পজিটিভ আছে, so that is called the sensitivity of the test. মানে it is a property of this RBS test, for example, যে আমার টেস্টটা কতটা স্ট্রং টু ডিটেক্ট a positive result among the total diseased person. So that is the property of the test. এটা যত বেশি হবে তত ভালো, তাই তো? That means the test is more accurate. The test will detect more positive among the diseased. Maximum যতটা হতে পারে পজিটিভ ডিটেক্ট করতে পারে. So that is the sensitivity. So if a sensitivity of a test is increasing, then that means a case is able to detect the true positives much better. Okay, so that is a good test. Then there is the other measures. Sensitivity holo people who test negative among those without the disease, that is called specificity. তাহলে specificity কি বলো? Who are testing negative among those without the disease. তাহলে specificity is D divided by B plus D into 100%. Now among the total not diseased, যেটা gold standard এ যারা not diseased এসছে, okay, in the gold standard whoever has come to be not diseased, I am assuming that they are not having disease in reality. In reality they are not having any disease. But again this RBS screening test will denote some of them as positive, some of them as negative. So whoever is coming as positive, they are called false positive, because they are falsely denoted as positive on the screening test. Why? Because they are supposed to be negative, they have come to be positive on the screening test, because it is not 100% accurate. Okay? And there are some people who have come to be negative also on the screening test. So they are called true negative. Among the true non-diseased, among the true non-diseased, among the true non-diseased, the true negatives, how much of the true negatives are there, that is called the specificity of the test. What does it mean? Means how specific is the test in determining the disease. Specificity joto badbe tar mane the people who are not having the disease, okay, will be correctly diagnosed as not having the disease. So that is, if the specificity increases, means that power of diagnosing who are non-diseased is increasing, and sensitivity increasing means whoever is having the disease, the power of detection of that is increasing. So that is sensitivity and specificity. Both of these are properties of the test itself, of the RBS test itself. Okay? So sensitivity and specificity, these are the properties of the test itself. So whichever population you take this test to, তুমি একটা population একটা rural এ করলে, এই RBS test টা যদি urban এ গিয়ে করো, the sensitivity and the specificity of the test do not change. Okay, they do not change, they will never change, because the power of detection of the disease among any population is a property of that test. Among the total diseased population, how many of them can be detected as diseased by the RBS, that is the property of the test only. And again, how many people are truly detected as non-diseased by RBS is again the property of the test only. So the sensitivity and the specificity, both are properties of the test, they do not change with the population. Okay, whichever population or whichever area you take that to, it will remain the same. So that percentage, whatever it will come out to be, it will come out to be nearly the same in all populations. So sensitivity, specificity, this will be denoted as percentage to calculate and give the percentage. Now comes এতক্ষণ properties of the test হলো, but what about the property of the disease? Okay, ডিজিজটার উপর কি তাহলে ডিপেন্ড করবে টেস্টের কত ভালো বা কত অ্যাকিউরেট? People who has the disease among those testing positive. So now those who are testing positive, how many people are having the disease? ঠিক আছে, মানে একটা ক্লিনিশিয়ানের কাছে বা একটা ক্যাম্পে একজন এলো, সে RBS করলো, they are doing RBS in a camp, they have tested positive. So what are the chances that they are actually positive? Okay, if you want to know the probability of the person being positive if a test is coming to be positive or the screening test is coming to be positive, that is called the positive predictive value. Okay, that is called the positive predictive value, PPV. So তাহলে what is the PPV? PPV is A divided by A plus B into 100%. A divided by A plus B into 100%. People who has the disease among those testing positive. Now তুমি row total টাকে নেবে, এতক্ষণ column total কে নিচ্ছিলে, এবারে row total কে নেবে as denominator. For the sensitivity and the specificity, you are taking column totals as denominator. Now, for the PPV, you are taking the row total as a denominator. এটা মাথায় রাখবে, ঠিক আছে? So, among those who are testing positive, who are having the disease, what is the probability of having the disease? That is called positive predictive value. Okay? Similarly, people without the disease among those testing negative, that is the negative predictive value, NPV. NPV is the people who are not having the disease among those testing negative. Sorry, B plus C হবে, C plus D হবে, C plus D into 100%. So, D divided by C plus D, it is negative predictive value. So, these are test negative. Whoever who is actually non-diseased among the test negative, that is called the negative predictive value of the test. Now, this PPV and the NPV, these are not the inherent properties of the test. Why I am telling you? In a population where the diabetes prevalence, for example, maybe in a very working class population, the diabetes prevalence, you will find them to be low there. And in some in a population which does not have that much working class, maybe service they are doing, they are having more diabetes. Okay? So, this population A is having, for example, 10% diabetes prevalence, the population B is having 25% diabetes prevalence. So, if I take that RBS test in the first population with 10% diabetes prevalence and someone is coming to be positive, so what are the chances that the person will be actually positive? It will be a little lower because the people who are having diabetes, that prevalence is lower, 10%. But if I take that to the second population, 25%, with that 25%, 1 out of 4 people are diabetic. Okay. In that population, if someone is coming positive, then there is a higher chance that that person is actually diabetic, right? So, it depends on the population. That is why the PPV and the NPV changes. The PPV and the NPV does not remain same in cross populations. That changes, and that depends on the prevalence of the disease. If the prevalence is low, the PPV is low. If the prevalence is high, the PPV is high. Okay? And opposite with the NPV. So, that is these 4 measures are there in the screening: sensitivity, specificity, positive predictive value, negative predictive value. Okay. So, this is all in relation to the screening test that you can do. So, we have already done this. As you can see, there the true disease status is there in the columns and the screening test results are there in the row. So, true positives, false negatives, false positive, true negatives. So, you have to, when you are writing in your answer, you have to denote, first of all make this 2 by 2 table, okay, give these headings and then denote which one of them is true positive, false negative, false positive, true negative. In the table you denote as ABCD and then you write the formula with ABCD, okay, or you write the formula like this directly, okay. But at least mention what is A, B, C and D. You have to mention that once in the problem, otherwise your marks will be deducted. You have to tell us that you understand this problem while solving it, otherwise we will assume that you have copied it from someone else. Okay. So, you have to mention what is A, what is B, what is C, what is D. তোমরা যদি এটাকে A, B, C, D করে দাও সেটাতেও অসুবিধা নেই, কিন্তু তোমরা ডিনোট করো, you denote what is A, B, C and D. If the formula is correct, mentioning that, then you will then again calculate by putting the values and calculating the sensitivity specificity. Okay. For example, there is written like this, for example, stroke, reference standard stroke, for example, by CT scan, okay, and then by self-reported stroke, that is the screening test. So, what is the PPV and NPV sensitivity and specificity? Again, it is detected and calculated by this. Understood? Kane denominator e ki ache? True positive plus false positive mane total jara test positive esche tader moddhe true positive kojon, and among the total negative, that is false negative and true negative, among the total negative how many of them are true negatives. By the sensitivity specificity, what is there? Among the total diseased, that is true positive and false negative, how many of them are true positives, and among the total non-diseased, that is false positive and true negative, how many of them are true negative. Okay. So, this is the sensitivity and the specificity. Now, predictive value, why is it different? As I said, it is more relevant to the clinicians and patients affected by prevalence of the disease or the burden of the disease in that population. So, prevalence increases when new disease cases are identified, and the prevalence decreases when a patient is either cured or dies. Okay. Prevalence and incidence আমরা আগেও পড়েছি, right? We have learned this before, what is incidence, what is prevalence. So, when a new disease is occurring, okay, and the occurrence is more, the prevalence is increasing, and if the person is cured or dies very rapidly, then the prevalence decreases. Okay, we already know that prevalence equal to incidence into the mean duration of the disease or the time. So, before testing, the probability of a person in the specified population having the disease is the same as the prevalence of the disease in the population. Means before the person is coming to me, okay, and getting themselves tested by the screening test, for example RBS, I have come to a population, I am assuming that the people I am screening, 10% of them will be positive, because I know the prevalence of the disease is 10% here. So, I am assuming that I will get 10% of the people I am screening positive. If that the prevalence value is equal to the actual number of positives I am getting, then the test is very good, but I will get less or maybe more. So, it will depend on the screening test also and the property of the population also. So, the prevalence of the disease is 1% of the population. You would expect approximately 1 in 100 people to have the disease before any testing, but I do not know how many people are actually having until and unless they are coming to test. Okay, I will do that. So, that is why the predictive value is different from the sensitivity and the specificity, because sensitivity and specificity, they are properties of the test. Among the, if you are giving any number of diseased people, how many of them will be detected, that is the property of the test. But if you are coming to a population and you do not know like how many diseased people are there, you do not know, you are just having this number of test positive. So, actually how many people of them are actually positive, then that is the depending on the population, that what is the prevalence of the disease. Thus, after testing, among those who are test positive, the chances of having the disease also increases with prevalence. So, now the prevalence, as I said, in a population with 10% and in a population with 25%, the chances of getting the true positive will be increased in the population with 25% prevalence, because the people who are coming to me in that population, the chances of that person being actually positive increases, because the prevalence of the disease is more in that other population. So, prevalence thus impacts the positive predictive value and the negative predictive value of the test. So, as the prevalence increases, PPV also increases, but the NPV decreases. Similarly, as the prevalence decreases, PPV decreases while the NPV increases. What I said. Okay, I have written this in this manner because this comes as a short note. PPV and prevalence are related, it is like that. It comes as a short note, explain why, like that. So, you have to make that table, denote what is PPV, what is the PPV, what is the NPV. First, you have to explain that, and then explain that why it is depending on the prevalence. You can explain that with an example, that I think 10%, 25% or similar to that, it is there in your book in the screening chapter, explaining with example. So, to write that example to get good marks. Okay. So, this is an important question that comes from screening. So, a hypothetical example, screening test A, 100 people are tested for the disease, 15 people have the disease, 85 people are not diseased. Okay. As you can see, 100 people are having the disease, 100 people are screened, 15 people are having the disease, 85 people are not having the disease. Okay. Calculate the prevalence, sensitivity, specificity and the NPV, PPV and the NPV. So, these numbers are all given, you first calculate this, calculate the prevalence first. What is the prevalence of the disease? What is the prevalence of the disease? 15% is the prevalence. Among 100, 15 are having the disease, so the prevalence is 15%. So, calculate the rest, what is sensitivity, specificity, PPV and the NPV with these values. So, কি করে calculate করলে sensitivity? So, 10 divided by 15, তাই তো? ঠিক আছে, into 100%, that is sensitivity. Specificity কত আসছে? কত আছে? 45 divided by 85, তাই তো? Into 100%, কত আসছে? 52.9, ঠিক আছে। তো percentage always mention, okay? Then there is the PPV and the NPV. So, what is PPV? (10 by 50 into 100%) 20%, I think. And what is NPV? 45 by 50 into 100 means 90%. Okay. So, just keep these values in your copy. As you can see, there is a specific value of sensitivity, specificity, PPV and the NPV. Okay. Now this hypothetical example 2, increase prevalence but same test. Now again you are going to into a community of 100 people, okay, there 30 people are diseased and 70 are non-diseased, and you are finding all these test results. So, now calculate the sensitivity, specificity, PPV and the NPV. So, the prevalence of the disease is changed now. Sensitivity কত আসছে? আগের বার কত এসেছিল? Sensitivity same আছে, specificity কত আসছে এখানে? 37 divided by 70 into 100%, তো কত আসছে? 52, 53% ওরকম আসছে, তাই তো? আসছে তো সবার? কারুর অন্য আসছে না তো? Then PPV and the NPV. Now what is the PPV and the NPV? আগের বার 20% এসেছিল, এবারে PPV কত পার্সেন্ট আসছে? সো এই পেছনে কথা বলবে না কেউ, করো, প্র্যাকটিস করো, না হলে কিন্তু পরীক্ষার হলে হাত দিয়ে বেরোবে না অ্যান্সার। So, the PPV is 33 divided, so what is 20 divided by 53. So, how much is it coming? 37, 38% it is coming. Okay. And NPV is 78%. 37 by 47 multiplied by 100%. So, as you can see, the PPV and the NPV has changed because the prevalence has changed. So, as the PPV increased, what happened? As the prevalence increased, the PPV also increased and the NPV decreased. Understood? This is for the category, like if I categorize people according to diseased and non-diseased according to a particular value. Okay, that is I am categorizing as diseased and non-diseased. Okay, কাউকে ডিজিজ বললাম নন ডিজিজ বললাম, যেমন আরডিটি টেস্ট যেগুলো হয় সেগুলোতে ডাবল লাইন আসলে পজিটিভ, সিঙ্গেল লাইন আসলে নেগেটিভ. So I can categorize like that and calculate like that. But what if I am dealing with continuous variables? Okay, what if I am dealing with continuous variables? মানে HbA1c and RBS, if I take that not categorize the patients like that, okay, like if someone has an RBS of 196, okay, are they really positive or are they really negative? What can I say about that? So if I take them as direct value, then how will I calculate the screening, the sensitivity, specificity? So ideally what should be there? That there are true positives and true negatives. That is, there are people who are diseased and there are people who are non-diseased. There is a clear cutoff point between them, that above that cutoff point whoever is there I will tell them as diseased, below that cutoff point I will tell them as non-diseased. Okay? So sensitivity should be 100%, specificity should be 100% for a particular test. Okay? Ideally that should be the cutoff point for the true positives and the true negatives. But this is not the reality. Okay, no test can determine that like that 100%. In reality it is like overlapping curves. Okay, that is the disease population is on the right, the healthy population is on the left, and they are overlapping with some values. Like the same people who are having 200 RBS, some of them might be actually diseased, some of them might be actually non-diseased. That was just elevated during that time. Okay, so which population are they falling into? And then if that is the case, if they are overlapping, then which cutoff point should I take? At which point should I take the cutoff that yes, I will take the cutoff of this screening test as 200, above the 200 I will tell as diabetic, below the 200 I will tell as non-diabetic. How did I take the 200? Okay, the disease and non-disease people are overlapping, right? So where am I taking the cutoff and how will I decide the cutoff? So as you can see, if such a case happens, then the sensitivity, specificity both becomes less than 100%. Okay, it is not perfect. And within that population, let's see, okay, yes, within that population as you can see, I have to take a cutoff point, and if I take a cutoff point for a particular test, for example 200 for RBS, above that cutoff point whoever are there and are belonging to the healthy population, they are false positives. And below that cutoff point whoever are falling within the diseased population, they are false negatives according to the test. Okay, according to the test these people are coming to be positive, but they are belonging actually to the healthy population. So they are false positives. And below that cutoff point whoever is there here, they are actually false negative because they actually are the diseased population, but they are falsely denoted as negatives. So that is how I will determine according to this cutoff point who are false positive, who are false negative, who are true positive, who are true negative. This is for a continuous variable. For example, in hypertension I can do that by SBP, in diabetes mellitus I can do that by RBS or FBS. Okay, by that I can determine, because people will overlap, that values will overlap between the two populations, the two diseased or non-diseased. So how will I know and what is the cutoff point then I need to take? Okay, that all these values are optimal. I have to take the cutoff point at a place where all these values are optimal, like the sensitivity, specificity, false positive, false negative. So I have to keep these errors at a minimum, okay, and these specificity and sensitivity at a maximum. If I take both of these at a maximum value, যেখানে একটা cutoff point নেব যেখানে দুটোর ভ্যালুই সবথেকে maximum আসবে, that is the ideal cutoff point for me. Okay, if taking that value gives me the maximum sensitivity and specificity together, then that is the ideal cutoff point for me, because that means then the errors, this false positive and false negative will be minimal. Okay, these false values will be minimal and the sensitivity and specificity, that is the true values will be maximum. That is the ideal cutoff point I have to take. So if I have this overlapping population where this is the not diseased and these dotted lines are the diseased population, and I take three cutoffs like this A, B and C across these test results, then what to do? If I increase the cutoff point from B to C, if I am increasing some cutoff point, then all these true negative become test negative as well. Means what is happening? If I am putting this cutoff point from B to C, then everyone below C will come out to be negative and everyone above C will come out to be positive. So now all the non-diseased population will come below C. So everyone who are not having the disease will be tested as non-diseased only, not test negative. Okay. So what is happening? People who are actually negative being tested as negative, that is called specificity, right. So I will increase the specificity if I move the cutoff point to the right or increase the cutoff point, then my specificity will increase. Okay. If I decrease the cutoff point from B to A, then all the true positives will become test positive as well. Means if I decrease the cutoff point from B to A, what happens? Everyone above this A is becoming positive, everyone below this A is becoming negative. Okay. Everyone above A is becoming positive for the disease, everyone below A is becoming negative. So what is happening is, I am taking this above A as everyone disease. So everyone who is actually diseased becomes test positive as well. So if I decrease the cutoff point, then my sensitivity will increase. Okay. So when is the sensitivity or specificity changing for a test? If I increase or decrease the cutoff point. Okay. That is when only the sensitivity and specificity will change. If I change the cutoff point. So if I increase the cutoff point, then what happens is my specificity will increase. If I decrease the cutoff point, my sensitivity will increase. Okay. So this is how you determine what to do. So I have to keep it at an optimum point where my errors will be minimal. Okay. What is happening is, if I am increasing from B to C or I am decreasing from B to A, if I am increasing from B to C, what is happening is, if the C is my cutoff point, everyone who is non-diseased will come out to be test negative, yes, but my false negative will increase. My false negative will increase as well, because then many people are getting eliminated as non-diseased. So the people who are somehow positive, they will also be eliminated as non-diseased. So my false negative will increase with C. Again, if I decrease from B to A, yes, all the diseased will be detected as diseased, but again many non-diseased will also be detected as diseased, because my cutoff is decreasing. So what is happening is, then the false positive will increase. False positive will increase. So my errors are increasing. So I have to keep my cutoff at such a point so that the errors are minimal, but the sensitivity and specificity can be reached at a maximum point, an ideal point, not 100%, it will never reach 100%, but it will be kept at a maximum with the minimum errors, that is false positive and false negative. So that is my goal, to make a cutoff point. So I just told this, lower cutoff point increases sensitivity, reduces specificity, higher cutoff point reduces sensitivity, increases specificity. So then choose a cutoff point which has maximum sensitivity and specificity and minimum false positive and false negative. This is the most accurate test. Okay. So what happens if I have many false positive results? Means if I decrease the cutoff point, okay, what will happen? There will be burden on the follow-up services. Whenever if a person is wrongly diseased as diabetic, then they will have to take the medicine, they will have to come for follow-up, they will go for tests. So there is a burden on the health services. There will be labeling effect, means person who is non-diabetic is labeled as diabetic, or a person who is not HIV positive is labeled as HIV positive. So there will be a labeling effect, there will be a problem with that. Implication of false negative result. If a person is wrongly diagnosed as negative when they are actually positive, there is failure to intervene, there is failure to give the treatment. Okay. So, I think just a minute, okay. So, that is when the ROC curve comes in, okay. Now, where will I put that cutoff point? That is when the ROC curve comes in. This is in case of only this quantitative value, the continuous value, okay, not the categorical values like that 2/2 table. It is in case of continuous value. What is happening is I am plotting true positive against false positive. If I am charting the true positive rate, that is 0 to 100% and false positive rate 0 to 100%, what will I get for each value, for each cutoff point that I can take, okay. So, first of all you will take a random classifier, that is 50% line or the diagonal line. What does this 50% line means? If a person is falling on this 50% line, if a cutoff is there on the 50% line, then what does it mean? 0.5%. Then 0.5% false positive rate and 0.5% true positive rate. If a test is like that, then you do not know if a person is coming positive, there is a 50-50 chance that that person is actually positive or a negative. So, what does that test? Doesn't have any value, right? The test is not good. So, anything below this 50% line is a good test, 50% or on the 50% line. Now, if something is curving above this 50% line, okay, it is becoming a better test. How? Because as the false positive rate is decreasing and the true positive rate is increasing, okay. The false positive rate is decreasing and the true positive rate is increasing. It is going in that direction, okay, that direction and above. So, the true positive rate is increasing near 100% and the false positive rate is decreasing near 0%. So, this is a receiver operating characteristic curve or the ROC curve. It comes as MCQ sometimes, okay. So, it is a ROC curve. So, the more the curve is towards the left, the true positive, the better the screening test is. So, wherever this point will reach a optimum point, that is the value that I have to take. That is the cutoff point I have to take. For whichever cutoff value this curve is coming to be the best, that value I will take. That will have the majority of the true positive rate, maximum true positive rate and minimum false positive rate, okay. So, area under the curve, again I said, if curve is above the 50% of the 0.5 line, then the test is good, otherwise the test is bad. So, evaluates the test over a range of multiple cutoff points, this ROC curve. So, plot of sensitivity against 1 minus specificity. This curve is actually false positive and true positive. True positive is sensitivity and what is false positive? 1 minus specificity, okay. 1 minus, this is specificity, 1 minus specificity is false positive, understood. This is true positive. True positive rate means the sensitivity. True positive rate means sensitivity. And then what is false positive? False positive is 1 minus true positive. What is true positive? That is specificity. True negative, that is specificity. So, 1 minus true negative is that is 1 minus specificity is false positive. So, sensitivity versus 1 minus specificity. If I do that, okay, then this ROC curve comes. If I plot for each of the cutoff point. So, plot of sensitivity against 1 minus specificity, the point of plateau of the curve is a J point calculated by Youden's index, that is sensitivity plus specificity minus 1. So, Youden's index is calculated by sensitivity plus specificity minus 1. So, for each cutoff point you calculate the sensitivity and specificity, you calculate this Youden's index. So, the maximum Youden's index value, that is the cutoff point you will take or the J point. So, this value of wherever it is plateauing, you can see at C it is plateauing. So, this is called the J point. How can you calculate that which J point I will take? I will take the J point which is calculated by the Youden's index. Youden's index is sensitivity plus specificity minus 1. whichever Youden's index comes maximum, that cutoff value I will take to be the cutoff value for my screening. So, maximum value of Youden's index gives the most accurate cutoff point, sensitivity and specificity. So, this is how you calculate the cutoff point for the continuous variable.